Our first case is from Dr. Nikit. Dr. Nikit, if you're there, you can present the case.
Yeah, so this is a very interesting case, actually. Never happened to see in last so many years of neurology practice. It's an 11-year-old boy who was diagnosed as autism and he was undergoing therapies, improving. Presented with a 7 days history of loss of vision. And that's it. On examination, pupils were not reacting. Otherwise, his motor examination and other cranial examination was fine. Ophthalmology evaluation, he was seen by ophthalmologist, and it suggested that there is a significant bilateral optic atrophy. No other clues on examination. His head circumference and things were all fine. More towards the autistic range rather than anything else. So no clues basically on history and examination of what could have happened, no drugs. And that is why we proceeded to do a scan. I was a little confused in the beginning whether to get a CT scan to look for optic nerve compression or an MRI, but then we weren't sure about whether he has underlying other metabolic problems which can explain both autism and vision loss. That's why I proceeded to do an MRI. And yeah, Dr. Nihaal, you can.
Yeah. Anything on the face or any bossing or stuff like that?
Nothing was there. His head circumference was 50 centimeters, which is okay for 10 years old. Not very large head as well. No frontal bossing, nothing was there.
Okay, sure. So we'll go ahead with the images. Yeah. So on top we have the T2 weighted sequences, and you can appreciate that the sinuses, in particular the frontal sinus, is widened. There is some degree of sinus disease, but I haven't got the diffusion changes, but these are not acute changes. Again, if you see the sphenoid sinus is also widened on the sidal images, you can appreciate that the clinoid process, the anticlinoid process also demonstrates this widened appearance of the sinuses. On the coronal, again, the frontal and the maxillary sinuses are slightly widened. There is some sinus disease in the left frontal sinus and mild in the ethmoidal sinuses. If you see on the coronal images, the optic nerves demonstrate reduced volume on both sides. Post-contrast imaging, there was no evidence of optic neuritis. But again, you can see that the sinuses are widened and with changes of bilateral optic atrophy. The rest of the brain parenchyma was normal. So we came to a diagnosis of pneumosinus dilatans. This is a review paper from 2014, and as you can see, the images are pretty similar to our index case. It is primarily seen in adults, but can also be seen in children with an age group of 8 to 87. Other associated findings can be meningiomas, arachnoid cyst, vision loss, probably due to external compression, and frontal sinus is the most common sinus to be involved. Single sinus can be involved, or multiple sinuses can be involved in the spectrum of diseases. At this point, I'll open the case for the panelists to comment upon.
As a clinician, I've never seen this condition.
Nihaal, what about the bilateral optic atrophy? Could we see any more of the optic nerve? Is there something happening on the left?
You mean on the coronal or over here?
Yeah.
Yeah, there is some fat standing.
So clinically, was it optic neuritis? Because you have similar changes on the other side as well.
Clinically, I think it was optic atrophy.
It was more like the optic atrophy rather than neuritis. And visual evoked potentials had a 0 response on stimulation of optic nerve. So this child underwent immediate functional endoscopic sinus surgery and decompression of optic nerve. The very next day we had done the scan. And the day after the surgery, he started having some light perception. 1 week follow-up, this child came for follow-up this Tuesday, and there is finger counting from 1 feet distance. So this is how rapidly there was a significant visual recovery. I mean, we went ahead with the surgical option irrespective of optic nerve. I mean, there are no responses in visual evoked potentials, but just because of this very short history of vision loss, we thought we might give him a chance. And there is, I mean, we are just waiting to see if there is any further significant useful vision he would recover to have. So just I thought we'll discuss this case only purely because of rarity of this case. Most often reported, I think, in third decade of their life, more often. And as Dr. Nihaal said, frontal sinuses and meningiomas are common associations. This child never had any of them. But I think here all the sinuses were involved and the sphenoid sinus was predominantly involved, causing the optic nerve compression, which was decompressed, and then child has some vision at least on 1 week follow-up.
Do you really think that it's a sphenoid sinus inflammation that compressed the optic nerve?
That is another theory which is described actually. So we have,
very unusual to do that.
I mean, inflammation as well as compression, both the things have been described in literature to cause the effect on optic nerve. So we are treating with this thing as well. I mean, we are treating with antibiotics because there was a sinus inflammation as well.
But to cause optic atrophy on both sides?
I mean, probably this is a long-standing thing. It's just, it became symptomatic a week before. Until then, he was probably holding, or it never came to a highlight because of his underlying autistic features and poor eye contact and all those things.
Yeah, what I'm trying to drive to is probably there's a long-standing background issue apart from.
Yes, I think the picture was a little bit muddled because of autism.
And how he was able to improve after surgery is like, because if this volume loss, I was not expecting too much improvement of it after any kind of procedure.
Yeah, that's what I mean. The history of loss of vision as per mother was very, very acute. It was only 7 days history. Yeah, and we thought we'll give him a chance, and at least there is some useful vision, which there was no light perception or any electrical responses in the optic nerve in the beginning pre-surgery, but now there is some useful vision which is there. So we hope this would improve. I mean, the guarded prognosis was explained, but then we thought we'll give him a chance.
Do you have diffusions here?
Caesar, I don't have diffusion, but there was nothing on the diffusion.
I'm just trying to understand like any kind of vascular explanation or something that we are not, because for me it's quite hard to understand the relation, although I see the anatomic location that could be explained somehow, but I don't see actually the correlation between the optic atrophy and at least not for me, and the change that you see in the bone. Just strange. I don't see so much compression of the optic nerves, neither. The optic chiasm seems normal, and so it's just strange to connect both things, although I see the location that's close.
Okay, if we have no further comments, we'll move on to our next case. Yeah, Dr. Nihaal.
Yeah, so this is a very interesting case actually. We still do not have overarching diagnosis for this child, despite of we been following him up for last 4 months. So this is a 10-year-old boy who had first episode presented with brief ataxic gait, and he presented in March 2022. There were no other focal deficits. And he came to us with imaging actually. And imaging was showing patchy foci of restricted diffusion in the posterior fossa. We had a broad differential diagnosis that time based on the history and examination, but the scan was more like either infective versus embolic sort of phenomena and stroke, posterior circulation stroke. We investigated him further, and he was found to have thrombus in the there was a thrombus in the vertebral artery, and on further vessel wall imaging a month later after the acute episode, he was found to have vertebral artery dissection in V2 segment. Meanwhile, we also had a differential of whether this could be a vasculitic phenomena to have alternate etiologies, which we worked up, and all the vasculitic workup, including ANCA complements, ANA, everything was negative. There was no history of trauma. This was a spontaneous sort of a stroke. On examination, he had hyperextensile joints, and there was a mitral valve regurgitation. So at the time of discharge, our working diagnosis was probable collagenopathy or leading to vasculopathy and dissection of artery. And this is what was proved later when we did a vessel wall imaging after a month. And he was maintained on antiplatelet agents. He was absolutely doing fine with 0 deficits. And 3 months later, he suddenly presented with another episode of transient ischemic episode causing focal weaknesses, focal patchy weakness. And we admitted him. Over a period of next 12 to 14 hours during the admission, he started having worsening encephalopathy, which wasn't there in the beginning of admission. And we had started him on double antiplatelet agent that time, and we also started him on anticoagulation. We did the scan. And the second scan is, I think we can discuss the second scan as well as first scan, Dr. Nihaal.
Yeah, thanks, Dr. Unfortunately, I don't have the vessel wall imaging one, which was done after this. The CD did not load. But
Okay.
this is the initial scan, I think done in March. And you can see there are multifocal infarcts in the bilateral cerebellar, inferior cerebellar hemispheres, more here on the left cerebellar hemisphere and along the PCI territory on both sides. There's a tiny focus along the subimpediment region in the right atria. This is on the MIP images. I cannot appreciate any abnormality. There's slight thinning of the right vertebral artery compared to the left. But that can also be a normal variant. The rest of the arteries are normal. So this is the most recent scan. And there are some chronic infarcts in the right inferior cerebral hemisphere, more acute, subacute ones in the vermis and along the paramedian thalamic nuclei on the right side. Again, on the MIP images, you can see that there is absence of the vertebral arteries, but on the source images, the basilar artery was slightly reduced in caliber, and the vertebral artery for a short segment did not demonstrate the appropriate flow, but you can see that there is visualization of the vertebral artery on the source images, but they're reduced in caliber. On the SWR sequences, the right PCI demonstrated this area of blooming, a possible thrombus, which was also not enhancing on the post-contrast study. Vessel wall imaging was done at this point. There is some wall thickening along the bilateral vertebral arteries. So these are the findings, and I'll open the case for discussion whether this is a vasculopathy or is it a vasculitis. That was the question.
Or was this a vertebral artery dissection? And on the initial scans, I thought there was some irregularity you were showing.
Yeah, so there was a scan after this. Vessel wall imaging was done at an external center, which was reported and demonstrated vertebral artery dissection. So that scan we don't have, and this is the scan after that. Done.
I think there is enough to call, and Dr. Shroff is on the call as well. I think a great neurointerventionalist in his own respect, actually, advice as well. I would have called that dissection based on at least a single shot images showing such focal irregularity and a little bit of prominence of the lumen as well. And the imaging would fit with that. Do we really need to pursue vasculitis and all that, given this obvious situation?
I think CRP is
also
also
put something on the chat as well. It's for the hosts and panelists, but I can read it for everyone. He says, VA dissection, right VA appears abnormal in the first study. He agrees with the sentiment of it being a dissection. My question really to the neurologist is, every time we have this, first of all, MR angiogram is badly interpreted in most centers. And the second thing is, how does it change management? For how long would you treat once we have proven it? And what is the threshold for a DSA, which would have been the test of choice, or at least a CT angiogram, before we started doing vessel wall imaging and all that? There will obviously be some enhancement in the vessel wall.
Okay, I mean, the only thing, we had discussion about doing DSA and all those things. But surgeons were of the opinion, or interventionalists was of opinion, that if you are suspecting a collagenopathy, DSA would have an additional risk of causing further dissection if you are cannulating the artery. So that was the only concern. We had sent the genetics to try and prove our hypothesis. We haven't got it yet. But yeah, in all sense, this was more like a collagenopathy based on clinical examination as well as mitral valve regurg, which is an additional finding, which can very well go with the collagenopathy. and hyperextensile joints and all those things. But the only thing is, why is it progressive? I mean, why there is a narrowing of lumen in the second instance when he had a second stroke? And are we expecting a progressive pathology despite of child being on anticoagulation? Antiplatelets.
I think that's a good question for the neurologists who do stroke imaging. Is Vivek on the call? I think he's very good with stroke.
Not sure if good bits to. That's a Waterloo for most pediatric neurologists, to be honest. Neurovascular imaging as well as neurology. The only thing for me, do you routinely do atlantoaxial imaging with these patients? The protocol where you want to see, as you also mentioned, laxity of joints. Is that something which is important here?
For posterior circulation, yeah, we do atlantoaxial, and we do a dynamic rotation if there is no pause in the arteries. So usually a CVJ junction, a CT scan is done. I don't think.
Did we do here?
I don't think it was done for this patient.
And it wasn't done. The dynamic neck study wasn't done.
And also a CT also wasn't done.
CT angio was not done. Yeah.
No, for the CVJ junction and the atlantoaxial.
No. I don't think so. No, I think Dr. Nihaal, there are images. We had done a CT including neck vessels as well as abdominal vessels, only sheer because of the doubt of vasculitic phenomena. There are images done in your center itself for CT angiogram of a neck vessel.
Dr. Shaw says multiple distal thromboembolism in recurrence, think of Bow-Hunter syndrome.
Okay.
Dr. Shaw, do we need to do a dynamic angio for the child? Or there's a risk of dissection?
And would you think of
Dr. Shaw says would be guarded, and we would do it in a non-acute setting, a dynamic angio. Dr. Nikhil?
Yeah. Okay. Maybe he's stable enough. He came for follow-up on this Monday. He is okay. The other thing which we could not explain here is why there was an encephalopathy. Based on the scan, there are no structures involved for someone to have an encephalopathy. We repeated the CT scan after 48 hours of doing this first MR, and that did not show increase in the infarct size. And our proposed theory was because the basilar artery and things were so narrowed, whether he is having hypoperfusion and that is what is causing encephalopathy based on the brainstem involvement. Clinical or functional brainstem involvement rather than acute restricted diffusion. Couple of weeks down the line, he is improving, but he still has some walking difficulty, some component of mutism, and some emotional ability, which can be explained based on the cerebellar involvement.
Did you check for homocysteine levels?
We have done all those things. So lipid profile, sickle, homocysteine, and the other, except protein C and protein S and antithrombin, like prothrombotic profile, rest of the things which will have at least some treatment implications, we have done most of them, including homocysteine.
Did you check also other two differentials, like the other two and Ehlers-Danlos, all the other causes that may present in the background of section? We have seen other tools without the section, but some narrowing the vessels, mainly distributed in the posterior territory, like multiple lesions. Normally they have some skin chains that are very characteristic, the reticular uniform appearance of the skin, and not so commonly seen in this section, but the irregularities of the vessels in the other two can be seen.
Right, data too. Probably that would be picked up on genetics, I suppose, if at all. I mean, that is one of the differentials which we have asked geneticists to look for.
Mhm.
Okay. So in the non-acute setting, maybe get a dynamic angio.
Dynamic angio, fine, absolutely. Thank you very much.
What about posterior circulation moya? Is that something one can think here? Or? So maybe DSA will be useful.
Mm-hmm. Yeah, probably. I mean, we only DSA, we were little skeptical based on the discussions, whether there is an increased risk of having another dissection, whether we will be iatrogenically worsening the thing if this is a collagen related disorder. That is why we did not go ahead and do, but that was the initial plan. But once we had some evidence later after a month, which also suggested that there is a dissection, we thought, okay, fine, we'll hold on to DSA and just do non-direct imaging.
So laxity, you meant to say more like fibromuscular dysplasia sort of growth.
Yeah.
That would be bilateral, right?
Yeah, bilateral, yes. But ophthalmology is normal, no lens dislocations. No, I mean, no EDS sort of things.
And Mahesh was asking, did you give just aspirin or what are you giving? Aspirin, clopidogrel?
First episode, we gave only aspirin. After second episode, he is on double antiplatelet. I mean, aspirin as well as cilostazol.
What? Sorry, second, clopidogrel, right? Did you say?
Cilostazol. Because I think there is some evidence in people from, I think, South Korea, they are using in moya sort of phenomena, they are using aspirin and cilostazol as like a dual agent. So whether
But you're not sure this is moya, right?
No, we are not sure. But I mean, purely based on the hypothesis that this is a progressive vasculopathy. Because of narrowing of lumen, progressive narrowing of the lumen. I mean, just as an additional benefit of doubt, we thought that has a dual action. So we may try and use it.
Because now studies, especially from Great Ormond Street, Dr. Ganeshan and team and Krish must be part of it. They have said that one should be having a low threshold for using aspirin clopidogrel combination for most of the neurovascular pediatric conditions, which might avoid even using anticoagulation. So even for dissection. So
okay.
So Krish, is that right?
Yeah, that is what Vijay Ganeshan always says here as well. I think that's what they have published.
Okay.
The tricky thing is, I don't know how the outcomes differ in terms of the long-term outcomes. We don't have that yet.
Because I think adults have a common practice of using double antiplatelet agent for dissections. But pediatric, it is not very certain as per the current available evidence. That is what I could. But there is an increasing evidence even in pediatric to say that we should use double antiplatelet.
Okay.
So the forum agrees that this is more like a vasculopathy and dissection-like phenomena. This is for benefit of doubt, this child was also on mycophenolate, and we had pulsed him with methylprednisolone as well for whatever benefit we had until we have a final confirmation about everything. But then I suppose based on the discussion, we can go ahead and stop the anti-inflammatory things based on the discussion in this forum.
Yeah, that's right. Good. Thanks, Dr. Nikhil. Thank you, everyone.
Yeah, thank you.
Just one final point about this case. What will be your frequency of surveillance imaging? Because they can have silent infarcts in posterior circulation problems. And you don't want a big one infarct which completely knocks them out. So that's up to Nihaal to decide out there locally what's to be done. But they can accrue a lot of infarcts silently in the posterior circulation territories. Be careful about that. They might only present with headaches or something, not obviously stroke.
Okay. Fine. I think maybe once in 3 months for initial year, or do you all agree? Or
Yeah, that should be fine, I think. 3 to
Yeah, I
6
think at least a couple of sequences to keep an eye on things if possible, you know.
sure. Okay.
Hope they don't have to pay for all the surveillance scans.
Okay.
Okay, we'll work it out. Yeah. Okay. Thank you.
So our next case is from Dr. Vivek.
Okay, so this is a 7-year-old boy who I have been seeing for the last 2 years. And epilepsy was fairly straightforward, very temporal lobe semiology seizures, where there was more of behavior arrest and version to the left. So more like a right mesial temporal semiology, brief events, not in clusters, but and just one big seizure. And initially well controlled with oxcarbamazepine, and then got not resistant, but the seizure frequency increased. So frisium was added, clobazam, and he still continues to have 1 to 2 events every month. And he's a well child. I'm not sure if I send the video. The child looks really well. Just to show he doesn't have any neurological deficits. This was his visit just recently. No neurological deficit. He's right-handed. He's a bright child, and there were no neurological deficits as such. It's just because of the MRI. That's why I sort of wanted to stress that there were no neurological deficits. Okay, so he had an MRI done 2 years back. At that time, I didn't know what I was looking at. I didn't have much of a differential. These are images from outside showing a predominantly white matter involvement around the frontal lobes and both the temporal lobes being involved. We didn't have a contrast study at the time, and it was fairly symmetrical. And I didn't have the MRI was disproportionately showing lesion as compared to what the child was and his epilepsy was, but I still did blood lactate, just hitting in the dark, which was normal. And then I did a whole exome, which they agreed to and was normal. I'm not sure what I was thinking, maybe vanishing white matter, but it's not vanishing white, but I was not sure. And homocysteine I did, which was normal. So hitting in the dark at that time. And then we did a MRI now after 2 years, because for a year they didn't come to me. And because, as I mentioned, the seizures had started to increase in frequency. So we did the second MRI just recently. So Nihaal, I will let you take over.
Yeah, second MRI.
I done a serum ferritin as well. And serum ferritin was normal actually, Kirish. I did do that. But again, that doesn't rule CNS HLHS.
Right. So second MRI, again, we have the same periventricular changes in the frontal lobes and also the temporal lobe abnormalities. There was some peripheral areas of restricted diffusion in the temporal lobes on both sides, as you can see on the low signals on the ADC. And on T2, again, these areas demonstrated iso intensities with mixed intensity in the central white matter. Central regions demonstrated hyperintensities. But again, just periventricular abnormalities as seen in the previous scan and the temporal lobe abnormalities. Contrast was done, and you can have this curvilinear enhancement in the temporal lobes and this nodular type of periventricular enhancement. You know, appreciate the periventricular enhancement on the coronal images. The pituitary gland, the stalk hypophysis is normal. Posterior fossa structures are normal. Rest of the brain demonstrated normal appearance. Could not come to a diagnosis, as Dr. Vivek said, but spectroscopy also was done, which demonstrated mildly elevated choline peak. There were some areas of lactate, but not significant. As Dr. Vivek said, West was normal. Could not come to a diagnosis, but possibility of a lymphoma. I don't know if the child will be normal in the case of lymphoma. LCH.
In 2 years, did you feel that the lesion has not progressed much?
No, it's not progressed much. It's not progressed much. The imaging findings are relatively stable. We didn't have the contrast for the first scan, so we don't know if the contrast uptake changed or not. But in terms of the extent of the lesion, I don't think they have changed. Maybe more well circumscribed But again, these are external images, but I think the overall extent is relatively the same or maybe slightly come down. But yeah, I would say not progressed. So these are the differences I thought. I think Dr. Mankad is also I thought of your case of a GFAP astrocytopathy, which had this typical confluent enhancement. But I think the GFAPs are more subacute or acute in onset and not chronic in nature, if I'm not mistaken. So now I'll open the case for the panelists for the discussion. I think Dr. Mankad has said HLH is a possibility.
Well, Vivek says he's done
History of
a little bit already, including the primary HLH genes. I think then you're heading to a biopsy, isn't it?
Yeah.
Yeah, it's just with non-progression of the lesion for the last 2 years and gliomatosis cerebri, that's not a possibility, is it?
It's not looking like that, and you would have a symptomatic child. It looks like you have a relatively asymptomatic child with all this happening.
Yeah, nothing has changed. He's so stable, except for those seizures. And they won't agree for biopsy, the family, but again, if the seizures, maybe I could use that as a pretext for, pre-surgical evaluation, and that stage we could do something.
Yes, of course, the yield of biopsy is questionable, but I can't think of the next step. You have considered all the possibilities by the looks of. Have you ever done spinal imaging? Is there anything in the spine? Maybe a better target for biopsy?
Right. We have not done the spine. We can do that. Yeah, not done the spine. The GFAP is one where one can, because GFAP patients, my 2 patients have been so stable. They don't behave like anti-MOG, or it's more of a milder form of autoimmune CNS illness. So I'm not saying this boy has GFAP, but that enhancement is where the previous patient also we thought of CNS lymphoma, and the child was so good. So disproportionately better child with a bad imaging. So maybe GFAP, maybe I could.
Would be too crazy to think like a differentials like Alexander. I think Aslan also mentioned the same thing at the same time. Alexander, like I'm not thinking that's like the classic appearance for sure, but I'm seeing enhancement going to the frontal horns and also temporal lobes, some signal change in the white matter, paraventricular white matter, with some frontal predominance, anterior predominance. I'm just thinking differentials here, like Alexander, perhaps in a very weird presentation.
This would have been shown in the trio exome, no?
Dr. Ved? Yeah.
Yeah, that would have shown. But again, if you don't give it as a differential, because a geneticist is as good as us, so I can ask them to again look at the primary HLH and Alexander gene. It's just interesting, that Alexander is a genetic form of GFAP disorder, isn't it? So,
Yeah.
So one could similar sort of imaging. So maybe do a GFAP antibody and also ask them if they can review their data again to look at the primary HLH and Alexander disease gene. Even though Alexander, I'm not sure will be such a well-preserved child with just epilepsy. So no cognitive deterioration or any CNS long track signs.
I think all of us in this group can safely say we have not seen an Alexander's like this. So the phenotype is not matching even radiologically. But
yeah.
if you're clutching on straws, we might have to exclude everything.
Yeah.
All right. Thank you.
Tell me something, if you biopsy this and if you get a GFAP, how will you distinguish that between Alexander's and a GFAP astrocytopathy? You'll get it's the same histology, right, by and large?
So in the GFAP patient, the one Nihaal just had shown, we had discussed before, we did a biopsy because we thought of a lymphoma at the time. GFAP was diagnosed later. and there was infiltration of lymphocytes around the fibrillary protein, whatever glial fibrillary protein in this patient. So maybe in the genetic form that should not be there. So immune lymphocytic infiltration. Yeah. So in this patient we did a biopsy. So that showed lymphocytic infiltration.
Hey, this is Manu. Can you guys hear me?
Dr. Shah. Yeah, please go.
Yeah, like everybody else, this is a fascinating case. I don't think I've seen anything like this. The only thing I do remember is some cases of MLC rarely can improve over time, but of course MLC never enhances, not that I have seen one. And then Vanderkanaap had published those occasional, inherited leukoencephalopathies, which rarely sort of reverse on their own, which could be one of the things that we could think about. The whole exome will cover the MLC gene, right?
It will. And I did actually give the differential as leukodystrophy panel for MLC, okay. And also I did vanishing white matter disease as a differential for this patient when I sent it.
Okay, fascinating. I wish we get an answer.
I'll keep everybody posted, see what comes out.
All right. Yep. Thank you. Thank you, everyone. To our next case again, Dr. Vivek.
So this is a 8-year-old boy who came to me with a more of a, not a chronic, but so like 2 months history of progressive unilateral hemidystonia with some chorioethetoid movements as well, more ethetoid distally in the right hand, and everything was on the right side. And there was no history of acute weakness or trauma, no history of chickenpox. And we'll maybe show the imaging first, the MRI, maybe the video, the first video when he came to me. Do you have the video? Nihaal, video?
Of this patient. No, I don't think I have the video.
Oh, okay. Okay. So he had a hemidystonia, and we did the MRI, and on the basis of MRI did some basic workup. Family did not, a very poor family, so somehow I could
Dr. Is this the one? Is this the child with the red shirt?
Yeah,
okay.
Shirt.
Sorry, I think I must have put it on a different case of course. This one?
Not this one.
Okay, sorry, I don't have the. I don't have the videos.
Right. So maybe we can discuss the imaging.
Sure.
And then, right. And
so
COVID was negative.
Yeah. Imaging, we have a focal hyperintensity in the putamen, does not demonstrate restricted diffusion. There is some areas of facilitated diffusion, so it's more of a chronic change. No other lesions. Spinal cord is normal. I think angiography was not done because cell wasn't upwardable. But we have this focal chronic ischemic change, at least on imaging. I think the question was, can it be chorea? Is that the question, Dr. Vivek?
Yeah, so if you remember, we had another patient who was similarly affected, but he had it in the caudate, right? Caudate nucleus before. And it's a similar sort of change, no diffusion restriction, same clinical, clinical presentation of hemidystonia with some chorea. But this child did not respond to steroid, and the degree of left-sided weakness, which you often see in chorea where it's weak but not hemiparietal. And a well child otherwise. No history of throat infection, nothing in the history, but Sydenham's was something which came to my mind. His ESR was normal, ESLO was normal, ECHO was normal. So I don't have an answer. And steroid didn't help him, actually worsened him. So when we gave him, because in Sydenham's, if you give steroid because of small vessel vasculitis, they nearly always do get better. So when he came to me after a few weeks of oral steroid, he was worse.
Any comments from the panelists?
I agree that in Sydenham chorea, most patients respond immediately to steroids, and the imaging, of course, there are exceptions, but as a rule is normal. So this is perhaps something different. Could that be a tumor? Low-grade glioma?
I would not think so. It doesn't expand the vitamin focal. I've not seen a focal lesion.
Nihaal, what is the chronicity of the story here? Exactly.
You mean clinically or on imaging?
Clinically, when did the problem start?
Dr. Vivek?
So I saw him a month back. So 2 months before that. So for 2 months prior to visit to me, parents felt he was weaker, slightly weaker on one side. And when I examined him, he had more of a right-sided hemidystonia with chorea. He also was choreiform, choreoathetoid movements. And he was not weak. It was more the movement disorder on one side.
Okay, thanks.
So-
I mean, there's a bit of volume loss, isn't it, in that area as well? Whilst we're thinking of common things, one thing not to forget is to follow this up in case there's a developing germinoma or something there. They can give you iron deposition asymmetrically like that, as you see here. And it's a location that we don't often think about germinoma instantly.
Do they have diffusion restriction, intense diffusion restriction, germinoma?
I think anything can restrict diffusion because they can be, the cellularity or the calcific content. I don't think the diffusion restriction is a total take away from that. And is it really fully restricting because you've got facilitated areas as
No, it's
well? On
not
that
restricting.
No, it is not restricted. It's not restricted.
Okay, yeah,
This one
yeah.
is not
So
one.
that actually is in favor of a process that could be developing there. And the other thing with germinomas is they can give you atrophy of that hemisphere. So people look out for those changes. If you have only one scan, that is why I asked you about the duration of problems.
Yeah, I remember seeing some case of germinomas that only the SWI was positive, and later on the signal change starts to appear in the late stage, only the atrophy, and no restricted diffusion for the offline germinomas are not so common as those in the midline. I think it's a good differential. And no history of infection, I think, yes, no history of viral infection or something that could explain some like residual change.
Yeah,
So no history of varicella and COVID IgG was negative.
Okay, sorry. I missed this part, sorry.
Okay, maybe we'll have a follow-up scan, Dr. Vivek.
Sure. 6 months, maybe 6 months if they come back to me.
Sure. Right. Thank you. We'll discuss the case later. I think Dr. Lokesh is still in OP. Next case is Dr. Kavita. If Sahil is there, you can take up the case.
Yes, sir. So he's a 17-year-old. He had no perinatal issues as such any. So 3 main complaints. There was global developmental delay since beginning. There was delayed achievements of walking. Speech was also delayed. He was poor in academics, and he was completely normal till 10 years. And what the mother is saying that he had walking difficulty, but not enough to make him fall. But definitely he had some spasticity. Mother is tightening of all the limbs was there, and was unable to do bicycling movements and everything. So that was there. The first symptom that started was spasticity, and followed by that, at 10 years of age, he started getting regression with epilepsy. So the regression was in speech, cognitively he got regressed, slurred speech, it was progressive. And epilepsy was well controlled. He was started on oxcarbazepine, and after which he got was considerably well controlled, and due to some financial reasons they stopped it, and after which he got infrequent seizures, like every 2 to 3 months he was getting seizures. On examination, there was a head circumference was okay. Intellectual disability was there. No neurocutaneous markers, with spasticity was there. He had cerebellar signs like intentional tremors, and power was 5/5 with brisk DTRs, and cerebellar signs were present. So based on a neuroregression perspective, since there was a spasticity first, so white matter was thought of, and the first MRI was done, leukodystrophy for leukodystrophy.
Yeah, so this is the first MRI done last year, and we have predominant superficial and subcortical white matter changes. some degree of volume loss. There's also involvement of the external capsule, the internal capsule, and the dorsal striatum also demonstrates slightly hyperintense changes. Bilateral dentate nuclei demonstrate the symmetrical areas of abnormalities. So after this scan, Sahil, what is the next scan was done after a year?
Yes, sir. So this was the first scan, and after which his epilepsy
was
burst.
L2 hydroxybutyric acid, if I'm not mistaken.
Yeah, yes, sir. It was reported that, and after which he was his epilepsy worsened. Previously, he was getting 2 to 3 episodes, 1 episode every 2 to 3 months now, and he's getting now very frequent 1 episode every 1 monthly, and the duration has also increased of seizures. So the other thing was that we had repeated another scan after a year.
Yeah, so this is the follow-up scan, and again you can appreciate a predominance of cortical involvement, relative sparing of the periventricular white matter. Again, the dorsal striatum demonstrates slightly hyperintense changes. Bilateral dentate nuclei has this symmetrical hyperintense changes. There's some degree of hyperplasia of the vermis. Corpus callosum is mildly reduced in volume. No cavitation or cystic changes in the abnormal white matter. Spectroscopy was done, which is pretty non-diagnostic, no abnormal peaks. ASL was done. I think this was part of a thesis, though I don't think it's indicated for L2 hydroxyglutaciduria. On top images, I cannot appreciate any hypoperfusion, but the CBF images were reported as hypoperfusion, which I think is normal. So just, I think it's a pretty straightforward case on the diagnosis. The subcortical involvement is predominantly seen in L2 hydroxyglutaric aciduria. The other differentials are as listed below. Again, the dentate nucleus abnormalities along with the subcortical and superficial white matter abnormalities is commonly seen in L2 HGA. The question was of epilepsy and seizures. I think, if I'm not mistaken, it is seen in L2 hydroxyglutaric aciduria. Sahil, what was the question?
So the ASL they had done. It was a part of a thesis workup for a student.
Okay.
And it was done, and it was showing hypoperfusion over both of the frontal regions, and it's so that's what we wanted to see, if it is normal or if it's showing hypoperfusion. So that was the first doubt, sir, in this case.
So I'll open the case for the panelists to comment upon the use of ASL. And
at least I can tell you from the mitochondrial disorder that is quite variable, depending on the stage of the disease and the activity of the disease, presence of resting diffusion. So if patients are, although they don't have so much cortical involvement, if they're in the context of some stroke-like presence, even without cortical involvement, they may have some areas of increased ASL, mostly in the subcortical white matter, and things tend to change. I'm not sure we have an answer for the ASL changes based on just one transversal imaging. I think they're variable and depending on how much of the white matter is involved in the chronicity of the disease.
I mean, the interesting thing is that it'll make a nice paper, but that's about it, I think. Are you all charging patients separately for ASL and all these additional packages, or it's just being done in the centers?
It was part of the thesis.
No, sir, it's not been charged. It's a part of a thesis, so they are doing
Okay,
it.
that's fine. I mean, if you want to test the hypothesis, what is your hypothesis?
Actually, sir, it's not mine. It's of
Hypothesis was
GR1 of radiology.
hypoperfusion in the frontal lobes, predominantly in the frontal lobes.
I think there are 100 causes of hypoperfusion in the frontal lobe in children, but with these leukodystrophy changes, you will expect some perfusion changes anyways. I don't think they're perfusing too well. You can see the atrophy of the brain as well happening in the background. Question for L2 hydroxy is, do you have a surveillance screening policy for the additional potential of developing tumors?
Kish, have you seen brain tumors in this condition on follow-up? I know that Sultan Patna has published this, but I think only one.
Again, I think every center probably has 1 or 2 examples lurking around, but then this condition itself is so rare. So when we see it now, we do an annual surveillance at least, but because children, when their neurology changes, it's very hard to know what's new and what's old, given the context of so much brain change already happening.
Annual open end?
Sorry?
Would you do annual MRI kind of open?
Yeah, at the moment, if we have a case, we do annual.
I've seen a 35-year-old patient walking around with exactly this imaging.
Yeah, unless the family is astute and any obvious change in neurology can be picked up early on, I think it depends on the situation. But for just a thought, because we shouldn't forget the carcinogenic potential of this mutation as well, right?
Thank you.
All right, thank you. The next case again, Sahil.
Yes, sir. He's a 4-year-old boy, non-consensual marriage, full-term LSCS, not cried immediately. Was one point, he was a very low birth weight baby and was shifted for an ICU for 5 days, and mother also had PIH. So the issues are, firstly, he has severe global developmental delay, and all developmental quotients are less than 20%. And he has had 2 episodes of seizures so far. Both were fever provoked, and he was started outside on some private practitioner by levetiracetam and clobazam. No further seizures since then. So when we saw this child, he had a gross facial dysmorphism, like coarse faces, low set ears, thick lower lip. So it looked more of like mucopolysaccharidosis, and we had sent his workup for mucopolysaccharidosis, urinary GAGs, which have come negative. The other thing is that he had underwent an MRI. So yeah, so that's what there is. It's showing splenial hypoplasia. So we wanted to know further differentials for this child.
So yeah, as you can see, the facial dysmorphism. We'll go to the images, but we showed it to our geneticist over here, and based on the facial appearance, she thought about possibility of a Williams syndrome. So just to keep that in mind, we'll go to the images. Skeletal
Can I mention that MPS patients are not getting microcephalic?
Yeah.
This would be very unusual.
Yeah.
They have large heads, Sanfilippo and Hurler and Hunter. And you have negative GAG in urine. So this is something else.
Yeah, got it.
Yes, sir.
So X-rays was done, and on the X-rays, the main findings were there was metaphyseal widening of the radius of the ulna, and these are the various differentials for this condition. The most common one being vitamin D deficiency. I don't think a vitamin D.
No, sir, it was not done. No, sir, it was not done.
Vestibular roofs are flat. Again, multiple conditions, skeletal dysplasia demonstrating these findings. The spine was relatively normal. The external images slightly pixelated. Supratental, no malformations, deep brain nuclear abnormalities, nothing in the white matter. But in the inferior cerebral hemisphere, I think the orientation is slightly abnormal. It should be slightly oblique or horizontal. They are more vertically oriented on the axial images. And there is partial hypogenesis of the corpus callosum. The dorsal ventral expansion is not appropriate to what we see in a normal child. Possible brainstem hypoplasia, but could be very mild. There is some inferior vermin hypoplasia with apparent enlargement of the fourth ventricle. So other than these findings, I'm not sure if you can put that all them together. So I'll open the case for the discussion.
I have no clue, but there are special radiologists or clinicians who are specialists in skeletal dysplasias. I would involve such a person. And they are collect like rare post stamps, and they can often figure out the differential diagnosis, or at least assist in targeting investigations.
Sahil, what is the next plan? I don't think patient is affordable for genetics or.
Yes, sir. We actually are trying to do it at a very low cost. We are just we have called them for follow-up. We want to get a full skeletal survey done. We have just done 2 this X-rays. The rest of which we'll try to get it at a free of cost or something like that. We are planning for a genetic. We have counseled them for a genetic test for this child, but I don't think so they are willing. It's a single child, and they don't want further child, so probably they won't.
If you do a skeletal survey, I'm very happy to line you up with a skeletal dysplasia expert at Great Ormond Street, who is Dr. Calder, or even Dr. Rafaya, who's in Sheffield, and they'll be very happy to provide an opinion, which might help you target gene testing because it's such an expansive field now. Is this brain scan belonging to the same child, though?
Yeah, it is.
Yes, sir.
Lots of abnormalities there, isn't it?
Yeah, but
Yes,
nothing
sir.
fitting together.
Sir, I'll surely let you know when they'll come back. We are going to do X-ray skeletal survey, the more X-rays, and I'll send you the PDF, sir.
Okay.
Try to send the full study in DICOM if you can to my
Okay.
email and with a bit of history so I can get the guys to have a look.
Yes, sir. Yes, sir.
Don't call me sir, please. Thank you.
Oh, okay, okay.
All right. Thanks, Sahil.
Thank you, everybody.
Next is from Dr. Ramesh. If Pawan is there, he can take up the case.
Yes, sir.
Yeah.
This is a 3.5-year-old child born out of non-consanguineous marriage. Sorry, it's a consanguineous marriage, and initially presented with at birth, child has flexed elbows and only has finger and wrist movements and able to move legs along the gravity with semi-flexed knees. By the time child has come at 3.5 months, arms and legs, child has improved movements, able to move against gravity, and they have given a few massages at home, and some physiotherapy has went on. And on examination, child is having temporal hollowing, and there is easily dislocatable shoulder joint, and there is significant paraspinal weakness, and testis on one side is undescended, and DTS are 2+ on bilateral knee. So it's basically a motor developmental delay which was gradually improving, and proximal more than distal weakness with normal cognition. And few investigations wise, the NCS was normal, and CPK was elevated around 3,750, and 2D echo was normal, and genetics was done, but it was a clinical exome sequencing, but it was inconclusive. And MRI, they got it done, and it was showing right parietal periventricular bleed, which is resolving.
Yeah, so again, slightly apologies for slightly pixelated images, but there was this right-sided periventricular abnormality, areas of blooming on the SWS sequences. We didn't have any contrast sequences, no vascular imaging. I think the gene came out to be a variant of uncertain significance for congenital muscular dystrophy. No features of CMD, at least the typical features on the available images on the brain scan. So it's an interparenchymal hemorrhage, possible vascular underlying vascular malformation. Given we don't have vascular imaging and contrast, it is pretty difficult to say. But I don't think it fits with the gene of the CMD, the CMD gene. I know
Our main doubt was there is a bleed, and there is easily dislocatable shoulder joint, and some hyper extensibilities of fingers is there. So any collagenopathies that we can think of.
But does this image explain the clinical context? And have you repeated the CK, which is very markedly elevated?
Yes, sir, we have advised them. They are yet to follow up, sir.
Yeah, I would like to add, I had also seen this child. The imaging would not explain the clinical phenotype of the child. It was like the child was totally floppy at birth, no movements at all, slowly improving with retained reflexes. So clinically, we thought of congenital myopathies and congenital muscular dystrophies with such a high CPK. And actually, the gene identified was POMGNT1, POMGNT1. However, it was a heterozygous mutation for an autosomal recessive condition. So it was only a single variant which was detected. So the question here was whether there is a phenotype match to the POMGNT1 gene, and should we go ahead with detection of a second variant by a different method, that is microarray, or do we look for other group of disorders like collagenopathies? That was the question.
So at least imaging wise, I think it doesn't match with the POMGNT1. More of collagenopathies, connective tissue disorders. Would be more of-
Okay. We have asked for a repeat CPK. We'll have to see, because even for congenital muscular dystrophy, usually they will not be so much improving. The child has improved a lot, right from no movements at birth to almost neck holding, partial neck holding now, and cognitively also very bright, no microcephaly. So there are a number of clinical pointers against it as well.
Okay. Next scan. Yeah, going back to again to Dr. Vivek.
Okay, this is a 10-year-old boy who had acute history of so he came a week after the illness to us, and he slept at night and the next day morning. So it was really acute left-sided weakness, left arm and left leg weakness, where he could not walk properly. And in a day or two, he improved slightly, but he was weaker on the left side, but became ambulant with support. His father is his father is an interesting guy. He thought when he talks to us also, he can sort of, he knows something about medicine. So he thought he could do something for his son. So he acted more like a chiropractor. So he thought there was some nerve problem in his left side. So he lifted him up from his neck the third day of illness, and the child became syncopial for few minutes. And then when he woke up, his weakness had increased further. So 4 days later, after this all happened in 3-4 days, and the family came to us, got admitted. He was again getting better. Did I send the videos of this child?
Yeah.
Yes. So if you see the swing of the left side, left arm is much less, and the left leg as well, but more in the left arm. Turns back, and the hemiparetic gait, the circumduction has just started. The left.
I think this is where he was unable to lift his-
Yeah, he was not able to lift his left arm.
Sorry.
Right.
Okay.
Yeah. So we did the MRI. We had few images from outside, and then we did a second MRI just so that we could get because the images were not that clear. So, but the first MRI importantly had contrast images as well. So I'll let you take over now.
Yeah. So non-contrast T1 sagittal over here, and we have some areas of T1 hyperintensity, most likely hemorrhage. There is expansion of the cord extending from the cervicomedullary junction up to the lower aspect of the cervical cord. T2 sequences predominantly hyperintense. Again, these areas of focal hypointensity suggest of hemorrhage. Perilegial edema is pretty less, but that we can appreciate on the contrast. Again, you can appreciate the widening of the cervical cord. On the axial images, this is the focal area of T2 hypointensity, most likely a hemorrhagic foci in the cervical cord. Post-contrast images, there is some degree of enhancement in the cervicomedullary junction and the upper cervical cord. The rest of the abnormality does not demonstrate any significant enhancement. Spectroscopy was done. I'm not sure of the focus, but it demonstrates a choline peak. I think I didn't put up the follow-up images. But based on the images alone, to think of intramedullary neoplasms, these are the differentials. Think you most likely ganglioglioma based on the heterogeneous appearance and the presence of hemorrhage. Astrocytoma is a differential. The other intramedullary tumors of the cervical cord, the hemangioblastoma is less likely given the contrast and the hemorrhagic foci. Ependymomas are usually seen in the lumbar spine in the pediatric age group. So I'm thinking of neoplastic etiology, and I'll open the case for further discussion.
Yeah, because it was reported as a myelitis, and the postulation was because the father lifted the child up, so therefore there was hemorrhage. But one could not explain that well circumscribed contrast enhancement.
Yeah.
So it was more like a neoplastic process than. He did get even steroids for a few days, which obviously will help even if it's neoplastic, methyl-ped, and his NMO-MOG was negative. But again, that was done again thinking people thought of myelitis as a possibility rather than because of the report. But looks more neoplastic.
Yeah.
I have also considered hemangioblastoma as a possibility in the context of von Hippel-Lindau, although this is very rare, but the marked swelling is compatible. I would consider as a simple investigation to do an abdominal ultrasound, as most patients have pancreatic cysts, and also look at the fundi, whether there are any ocular vascular anomalies.
All right, I think now we're thinking of neoplasm, as Dr. Shroff has also mentioned. Yeah. For next case, again from Dr. Vivek.
This baby, there was some, this presentation is because I think the imaging is typical, but there were some findings which were more as reported, was not sure if they are there as was reported. So I'll just present the history first. So a 5-week-old baby who was well at birth, there were no concerns, and then acutely came to us with a history of irritability, decreased feeding, bulging fontanelle, features of raised pressure, and drowsy. And actually, I have written no seizures. I sent the patient's history. I think the day the child got admitted to us, and the next day she started to have seizures, left focal, so much so, and now I feel why I wrote no seizure, and I didn't check it again, that we had to put her on midazolam infusion and continuous EEG monitoring, and now it's 10th day of illness, and she's been off ventilator for 3 days. Seizures have stopped. So 4 or 5 days of left focal seizures also from day 2 of admission. So when she came to us, it was more of a raised pressure features, but during admission, she developed status on the left side. She had normal coagulation, and there was some cells, CSF, and glucose was low, 30/104. Protein was normal for age. So for 5-week-old, even the cells could be considered normal. Hemoglobin was really low. We gave transfusion. It's 9 now. And then we did the imaging, which Nihaal, do you want to?
The seizures, the imaging was after the seizures or before the seizures?
The imaging was during that time only. So I think day 2, so we probably missed seizures. Child was having, so this was done during the time of seizures, I will say, right? So we missed subtle seizures on day 1.
Okay. So the imaging on top, we have the diffusion weighted sequence.
And CSF, pressure was normal. CSF pressure was.
Yeah, so we have extensive area of restricted diffusion, predominantly involved the cortex and subcortical white matter. With a posterior to anterior gradient, the parietal occipital lobes are more predominantly involved than the frontal lobes. Peritrigonal and spina of the corpus callosum are also involved. Posterior fossa structures did not demonstrate any changes on the DWI images. These are the gradient sequences, and you can appreciate that there are subdural hematomas along the falx and the left parietal region, also extending up to the central regions. Posterior fossa, again, you can appreciate this thick subdural hematomas on both sides. Some areas of intraventricular hemorrhage in the parietal occipital horns, and some foci of hemorrhage in the temporal lobes and the frontal lobe. Again, T1 non-contrast, you can again appreciate the subdural hematomas on predominantly along the posterior aspects of the brain. Again, here bleed in the areas of the vein of Galen. The orbits were normal. I could not appreciate any hemorrhage in the orbits. MIP images of the suprachiasmatic sinus demonstrated this defect, but on the contrast images, you can appreciate that it is actually, it is patent, but it's probably compressed due to the underlying subdural hematoma. So based on these findings, think of various causes of neonatal intracranial hemorrhage. Bleeding diastasis is one of the common conditions. The vitamin K was given. Child had hemoglobin, so low hemoglobin, so maybe that can explain it. Hypoglycemia again can present with this posterior to anterior gradient of cytotoxic edematous changes. Thought of a possibility of abusive head injury, but maybe less likely. But given the subdural hematomas, and if we consider the diffusion changes as hypoxic changes rather than hypoglycemic or a mixture of both, possibility to be considered. These are just differentials for not considering NAI, but these are just differential on the imaging aspects of NAI. Infection can cause it, but I think the CSF was relatively normal. There is no hemorrhagic disease of newborn given the vitamin K supplementation. There was no birth-related injury. Doesn't fit into Menkes or any other inborn errors of metabolism. So at this point, I'll open the case for discussion.
There were no retinal hemorrhages.
Yeah,
it's a male child, first child of the family, and we did try to probe about the NAI, because NAI is something, and then it was reported as cortical venous thrombus. So because of the venogram and the blood in the region of vein of Galen.
Yeah.
So there was a lot of confusion. So whether this is subdural collection bleed or there is a thrombus in between, and the etiology, because the coagulation was always
in the contrast. You can appreciate the vein of Galen, the contrast images.
Yeah.
Also in the area of MIP images, this is more due to compression, because you can see the flow
due to compression, right? Because which is very interesting. That one can think of it as a thrombus, but this is all because when you give Clexane here, it can be counterproductive.
Any comments on the constellation of findings? If anyone wants to comment on that. Do you attribute the changes of the diffusion to hypoglycemia, Dr. Vivek? Was it significant enough to cause these changes?
No. The blood sugar is 104.
Okay.
This is something due to subdural, they must be compressing the vessels posteriorly, because not in this child, but what I felt in all patients of late hemorrhagic disease of newborn, because this is a hemorrhagic disease of newborn, so but not because of coagulation. Okay. They always often, because of the compression from the blood, always have infarcts. And for me, I realized it's just out of context here, but these infarcts are the biggest problem. We chase the blood. We call the neurosurgeon to drain it, and sometimes, and we often don't drain them because it's more the infarcts which is a problem than the blood, because it causes status which often is not picked clinically. If you put the EG on, you will be having continuous electric seizure activity. So for these patients, even for this one, the thing which I've realized in LHDNs, if one has a facility, one should put them on continuous EG monitoring, because that's going to cause more problem rather than hemorrhage.
Okay.
So for me, this was more the infarct due to maybe the compression from the subdurals. Is that possible? The posterior infarcts? Sugar was always normal.
They look pretty symmetrical, and I wouldn't call it infarcts per se. Looks like more of a metabolic process or hypoxic process than infarct. Infarcts usually more focal segmental. These are actually more symmetrical.
Would you call them in the watershed region? Maybe hypotension because of loss of blood?
But they're extending. It is
extending
more,
further.
Only involving these regions, then maybe watershed, but they're going anteriorly. I would probably think of hypoglycemia, hypoxia rather than infarcts. And venous infarcts, if you're suggesting any venous etiology, they are more hemorrhagic than just normal areas of diffusion changes.
So actually, you are right. So this is also unexplained. The posture infarcts, the blood is unexplained as well. NAI still remains an important possibility.
Yeah,
I still feel.
I think it should be considered. Yeah. Because given the posterior dependent subdural, they're commonly seen, but a normal or a retinal examination doesn't rule out any, which we have discussed previously also. So,
And does this subdural needs evacuation? Is it something?
I'm not sure. I think the neurosurgeon will take a call. Unless it is causing compression on the cerebellum, especially the cerebellar are pretty thick.
Yeah, and there's no hydrocephalus, so this must not be compressing the ventricle.
Yeah, yeah. Do you plan to get a skeletal survey or a CT head?
So we did a skeletal survey, which was normal. We have not done a CT head. So
sure. And no spine screening to see any hemorrhage in the
we have
spine?
not done, no, we have not done a spine.
Okay.
We'll do that.
Sure. All right. Thank you. Next set of cases from Dr. Kamte. I think he's not there. Maybe one of his fellows can present the cases quickly.
Yeah, this is a 6-year-old male child who was first born of a second-degree consanguineous marriage and has come with the complaints of global developmental delay and had only started sitting with support at 6 years of age. Poor language, speaks only bisyllables, and but normal birth history, and has microcephaly, chorioathetoid movements on examination. Presented with a chromosomal microarray done, which was negative before he presented to us. On clinical differentials were of structural malformation or intrauterine infection of torch, and MRI scan was done. Findings will be shown, and thereafter we have done genetic evaluation, which has confirmed the diagnosis.
Yeah. Okay, let me show the images first. Okay. So the MR images, on top you have the T2 sequences, sagittal, you have the hypoplasia of the brainstem, predominantly in the pons, a hypoplastic and atrophic vermis. The cerebral hemispheres are almost not, are also severely affected. If you see on the FLAIR images, also appreciate on the T2 sequences, the cerebral cortex is hyperintense. And there is also a hot cross bun sign, which you see the hyperintensities along the pontocerebellar fibers and the median raphe nuclei. On the FLAIR images, again, you can appreciate the hyperintense cerebellar cortex and also the hot cross bun sign on the pons. No great foci of blooming in the cerebellum to suggest a possible antenatal injury. Supratentorially, no structural malformation, but could appreciate the thalama is slightly reduced in volume and demonstrate is T2 hyperintense changes. No corresponding T1 hypointensities, though it's not there, and no corresponding areas of blooming on the SWA sequences. But these are the only abnormalities in the supratentorial brain. If you concentrate on the posterior fossa structures, cerebellar atrophy with T2 hyperintensity of the cerebral cortex. These are the various differentials, ever increasing list, but yeah, these are the common changes common pathologies which can be seen with these changes. Hot cross bun sign is not is suggestive of olivopontocerebellar atrophy or pontocerebellar degeneration. So any disorder causing pontocerebellar degeneration can present with hot cross bun sign. As you can see, the differentials are again vast. This is an example of congenital disorder of glycosylation. This is from the paper of Dr. Rossi, and you can appreciate the findings are similar to our index case, cerebral atrophy with cerebellar cortex hyperintensity and the T2 hyperintensities along the transverse fibers and the median raphe nuclei. So yeah, you can go ahead with the whole exome.
So the whole exome sequencing showed 2 genes which were NDOFS1, which was homozygously inherited, and of autosomal recessive type nuclear inheritance, which is indicative of a mitochondrial complex 1 deficiency, and SLC39A8, which is also homozygous, which is a for CDG. With the MRI imaging, it falls more in favor of CDG, is what we concluded.
Any comments from the panelists on the images? Ivan?
May I ask, are the genetic variants classified as pathogenic, and have you investigated the parents?
Parents have not yet been investigated. The genetics have been classified as pathogenic. Yes, the variants.
Both variants or just one? So
I am sure of the CDG of the NDUFS. I am uncertain as of now. I will need to check that once again.
Okay, if there are no further comments, we'll move on to our next case. So we are taking it as a possible CDG.
it would not be the straightforward CDG 1A, but a rare variant of TAPE2N. Can you do transferesis in serum? So-called isoelectric focusing to see whether there is a particular pattern in the serum, which would allow you to have more power to call it a CDG type 2.
Yes, we can try either getting the parents tested, or we can go ahead with the transferrin, the testing for transferrin glycosylation. So we'll try to get that done to confirm it.
Thank you, and we look forward for a feedback to learn from you.
Thank you. Thank you.
Thank you. To our next case. Yep.
So the next case is she was a 5-year-old male child who came to us with the first episode. He was diagnosed with the first episode of nephrotic syndrome in earlier this year, that is Feb 2022. He did not respond to the usual treatment. He persisted to have edema and proteinuria. And after 1.5 months, he was diagnosed to have steroid-resistant nephrotic syndrome. That is in March. His renal biopsy showed membranous nephropathy. Then he was started on steroid-sparing agents, that is tacrolimus, for which he developed AKI. Then he was switched to cyclophosphamide. He had persistent hypertension, sir. And then now he presented to us with one episode of seizure, following which he had reduced vision and hearing. And that was acute for past 2 weeks. And now the issues are persistent hypertension requiring almost 3 antihypertensives. And his lactate was high, sir, 58. And and we had done an MRI because he came to us with one episode of seizure and reduced vision.
So I'll show the MR images and maybe you can take the discussion after that. So yeah, we have the diffusion weighted sequences on top, and you can appreciate areas of restricted diffusion involving predominantly the cortex, the cingulate cortex, the parietal regions, more on the right side, the pulmonothalamic nuclei bilaterally, but more severely on the right, the cortex and subcortical regions on the, again, the right temporal and occipital regions. Coming to the temporal and occipital region here, again, we have bilateral involvement, predominantly of the cortex, asymmetrical involvement. Posterior fossa structures were normal. There is some degree of volume loss in the supratentorial and infratentorial vein parenchyma. Again, some hyperintensity corresponding to the restricted diffusion. The gradient images did not demonstrate any areas of hemorrhage or mineralization. Slightly reduced volume of the corpus callosum, but otherwise, sagittal images do not demonstrate any other findings, and maybe some reduction of the midbrain. Again, generalized reduction in the brain volume on the T2 weighted sequences. Just to ask, was this what kind of a seizure was it? Was it status or just?
No, sir, it was not a status. Not a status.
Okay, so possibilities were considered were press given the hypertension, but they usually present with facilitated diffusion. Diffuse cytotoxic edema, predominantly in the cortex, is slightly atypical. ALRD, I don't think matches with the clinical and the clinical criteria of the child, though it can have cortical and pulmonothalamic nuclei changes. Infection is not considered in this patient. Another differential was, this is a case from Caesar. MELAS is a possibility, but I don't think the child had any hemiparesis or any weakness on one, if I'm right.
No, sir, no weakness, but he had dystonia.
Okay. And given the lactate, was it a single reading lactate or?
Single reading, sir, single reading.
So MELAS is a possibility. Again, herpes less likely, there's no infective changes. PRES, again, as we know, the diffusion is usually facilitated rather than cytotoxic. Ischemic changes are less commonly seen, less for this patient. Thought of another possibility of MOG antibody given involvement of the thalamus and also the particular regions to be considered. And now I'll open the case for further discussion.
It's interesting to see so much volume loss. There's no history of
I think the child is on chronic kidney disease with possible steroids were given. I'm not sure.
Steroids were given, sir. Steroids were given.
So that can explain the atrophy, I guess.
Yeah, I assume that no liver function was normal.
Yes, sir. Liver function was normal.
Yeah, because actually I agree with the differential of MELAS, but normally in this age with so much atrophy, POG is also a good differential to remember. I think when you see so much volume loss and there are different forms of POG-related disorders, MELAS would work well too. I think mitochondrias are good differentials here to include. And also those, I would also include some canalopathies in the differential, like.
Would you include Paul-G, Caesar?
Sorry?
Would you include Paul-G, but I think the liver and them?
Yeah, POG-related disorders, I think it's a differential to include because of the volume loss, thalamic chains. Even it could be related to the treatment. I see that too much volume loss, and I assume that POG is a good differential to include, mainly because I'm not seeing history of stroke-like episodes. At least you didn't describe stroke-like episodes, and POG can present also stroke-like episodes, but not so.
I don't think this child had a stroke-like episode.
No, sir, he didn't have.
Yeah, so I
think the seizures,
seizures of POG are quite
partialis continua type of seizure, or?
Sir, it was a generalized seizure, which was in the outside hospital. In-house, we didn't have a seizure.
Okay. And this boy has ongoing hypertension despite 3 medications.
Yes, sir. Yes, sir.
This is, for me, although we see some asymmetry in favor of PRES, I mean, more common things are more common. Why should he have MELAS in addition to his nephrotic and hypertensive constellation? Of course, double trouble is possible always, but if I try to find just one solution for everything, PRES would be my favorite.
Yeah, my only concern, like if I go to the parallelic region on the right, I have the impression that something happened before, because I'm seeing some acute change with restricted diffusion and some chronic change in the parallelic region. So I was assuming that there's just not one insult here, but more than one insult. So if I'm thinking I lap things, it could be still PRES with more than one insult. But like the parallelic region on the right, there is certainly some encephalomalacia. You can see the right flare sequence on the bottom there. I think I don't see, even if you look for the precentral gyrus is symmetrical, and there's some, I assume there's something going on that was not just an acute episode. That at least was my first impression.
What's the follow-up? I mean, what's the plan?
So we have sent the mitochondrial as well as the whole exome sequencing, and the child has been discharged home. So today they went home. So on follow-up, on 3 anti-hypertensives, we have discharged them.
Okay.
And we have started them on Norways. So on follow-up, we have to just see.
Okay, if possible.
That's interesting. You started Norways, isn't it? Because the only mitochondrial disorder which could explain with everything together would be CoQ deficiency, right? Nephrotic syndrome is something which happens.
Yes, sir. Yes, sir.
Yeah.
Okay, please get back to us the feedback if possible.
Sure, sir. Sure.
And to your last case.
So here we had a 16-year-old girl who presented with multiple episodes of vomiting for 4 days and followed 2 days later by left-sided and then right-sided hemiparesis. So she had UMN type of quadriparesis with UMN type of bladder and speech difficulty. Along with this, she also had drooling, hypophonia, and bilateral internuclear ophthalmoplegia. And her fundus examination was normal. She was intubated in view of bulbar palsy and weakness, and that is when we had taken over the case. And around 4 to 5 days later, she was extubated after giving IV methylprednisolone pulses and first dose of rituximab. We had clinically suspected area postrema syndrome and got an MRI done.
And the MRI, supratentorially, there is some degree of volume loss, but no structural abnormalities, no focal lesions. The level of the pons and the vermis, again, some degree of volume loss in the vermis, but again, no focal lesions. Coming down to the region of the area of postrema and the medulla, you can appreciate the hyperintensity edematous changes in the medulla. This is the DWI and the ADC. There is some restricted diffusion, but it does not reverse on the ADC, so probably T2 shine through over there. On the sagittal images, again, you can appreciate the predominant hyperintensity. The changes are in the lower, involving the medulla and the area of postrema. Possible myelitis in the cervical cord, given the axial images. There is some degree of hyperintensities over there. Orbits, optic nerves do not demonstrate any edematous changes, though contrast wasn't done. Spectroscopy is done. I don't think it is indicative of anything. Based on that, I have possible rhomencephalitis, but the child was relatively neurologically well. So that is a possibility on the imaging. Another possibility was demyelination, and these are different areas involved in the various demyelinating disorders. ADAM has more multifocal involvement, can involve the entire brainstem, whereas NMO usually involves the area postrema, that is the dorsal aspect of the cervicomyelitis junction, and can have cervical cord myelitis. Multiple sclerosis again has focal lesions rather than band-like involvement as seen in the NMOs. On axial images, again, it would better demonstrate the differences on imaging. MOG antibodies, another demyelinating disorder, but they usually is more confluent and can be unilateral or bilateral. Area postrema, as in the aquaporin for NMOs, is commonly involved. And MS, again, we have focal lesions. I'll not go into the various imaging aspects. I'll open the case for discussion after you give the diagnosis. Do we have a diagnosis of an NMO?
Yes, sir. Actually, we got aquaporin 4 IgG antibodies to be positive and MOG was negative.
Okay. Any of the panelists want to comment on the imaging or the clinical findings? All right. We have 2 more cases I'll quickly go through. I think we have Dr. Lokesh on board now. Yeah. Dr. Lokesh,
Yes.
Geeta, you want?
This was a 6-year-old female child, sir, healthy child with normal development and with acute presentation, only cough was there and fever for few hours. Then the child presented with like headache, vomitings and unresponsiveness for 2 hours prior to the admission, and she developed quadriparesis. She had a tonic posturing with uprolling of eyeballs, and she had poor breathing efforts for which she has to be intubated and ventilated. And later on in the course, she had this autonomic disturbances in the form of like labile BPs were there requiring multiple inotropic supports. And there was also eye changes, like there was a adducting nystagmus in the left eye, right eye was there. And on prolonged ventilatory support, and also initial blood cultures and all, they were positive for pneumococcus. Even the tracheal culture was positive for pneumococcus. So, and she also had a sudden deterioration with the, so we have to do a imaging. Then the imaging was suggestive of tonsil.
Okay, just go directly to the imaging. Yeah, so imaging, we have these multifocal punctate areas of cytotoxic edema or infarcts in the bilateral superficial and deep white matter, involving also the splenium of the corpus callosum, the right temporal lobe, possibly the bilateral temporal lobes. The majority of the findings are in the posterior fossa. We have the zero restricted diffusion in the bilateral cerebellar hemispheres and also involving the cerebellar tonsils. corresponding hyperintensities on the flare. On the sagittal images, you can appreciate that there is tonsillar herniation resulting in compression at the cervico-craniovertebral junction. That is an acquired GRE1 deformity. Contrast images, nothing in the supratentorial brain parenchyma. Mild foci of enhancement in the left cerebellar tonsil. Possibility of infarcts to be considered, but on the contrast imaging, the vertebral artery and the basilar arteries at least did not demonstrate any filling defects, or the contrast uptake was pretty uniform and normal. Follow-up based on that, we thought of a possibility of rhombencephalitis or infective process causing these changes. Yeah,
so we had a biopsy, like a decompressive craniectomy was done, and we took that cerebellar lesion, whatever is that, the pus we have sent for the cultures, and it was showing Acinetobacter infection, sir. So later on, other cultures also turned to be Acinetobacter.
Yeah, and, just a minute. So this child, while on ventilator, initially she had movements of the limbs, but suddenly she developed quadriparesis. Then we did this initial scan. After the initial scan, the discussion was obviously child's supratentorial compartment looked reasonably good, and because of acute compression onto this sort of medulla, the discussion was whether decompression would help and whether the child will be able to have her breathing again. So for that, we counseled the family that there is a very small percentage that this child can actually breathe and walk again. And this one option is there, but whether you want to do it or not, the parents wanted to do everything. And then the decompressive procedure was done, and also biopsy was taken. And that's a biopsy which it was actually not a tissue from the tonsil. There was an exudative process that was showing only exudative infiltrate and grew Acinetobacter. Previously, 1 year back, the child had head injury and was admitted for it. Non-operative treatment was done. There was no obvious CSF leak demonstrated, or historically also there was no obvious CSF leak in this child.
Yeah, so the follow-up images, we have some new areas of restricted diffusion in the right frontal region. The tiny changes in the white matter are same, also spleen of the corpus callosum. Again, similar changes in the posterior fossa, but there is some progression involving the midbrain also now. Interval after craniectomy, there is improvement in the compression of the craniovertebral junction. Some areas of microbleeds in the splenium of the corpus callosum. This is just a comparative of the post-op and pre-op images. The cord edematous changes reduced, and there's also improvement in the tonsillar herniation, and you can appreciate some degree of CSF between the tonsils and the dorsal aspect of the brainstem. So thinking the overall imaging diagnosis was rhombencephalitis, but I could not find any literature of Acinetobacter causing rhombencephalitis. These are the common conditions causing rhombencephalitis, and again over here also we don't have Acinetobacter causing as an organism causing rhombencephalitis. So anyone has any experience with that organism causing these changes in the posterior fossa? Question.
We discharged this child today. She's still on ventilator, home ventilator. She's gone to a rehab setup. Still not much of movements, very occasional movements at the shoulder, almost 20 days, or how many days away from the tracheostomy and ventilation now?
25 days, sir.
25 days, yeah, 25 days. No limb movements, cognitively completely fine. We are not sure what is going to happen for the quadriparesis and the respiration. So we're just hoping that some improvement will happen over a period of next few months. Once again, the ethical dilemma, whether we should have given that option of decompression or not, given the first imaging. What would other pediatric neurologists would say, or other neuroradiology colleagues would suggest?
I think the compression is significant, Dr. Lokesh, at least on the first imaging. So I think, yeah, decompression we would have suggested decompression, at least imaging wise.
Yeah, now the question is, yes, decompression.
Yeah.
Once the child is quadriplegic, the reversibility, the amount of reversibility is what we don't have an exact idea.
Yeah.
We have had I had only one child in Bristol who pneumococcal meningitis with the herniation like this, and he was decompressed and he was stuck to ventilator for 9 months from that time. So other than that, I don't have exact experience of these kind of compression and decompression. So that is why if anybody else had experience of how the outcomes of these children, it helps to counsel these families in later.
I have no experience, but I would not expect much from further decompression. You have still some CSF around the brainstem and the upper cervical cord, no?
Yeah.
Yeah.
I think Lokesh is asking, would you have done decompression in the first go as itself, right? Is that right, Lokesh? Did you?
Yeah, we did the first
would
time
you go
itself,
for a decompression?
Yeah, within
Yeah,
immediate.
would you go for a decompression initially itself? That's what the question is.
Yes, that's
But,
the question. Yes, exactly. Yeah.
Yeah. So for me, I've never seen it, but a cognitively normal child, and if you don't do a decompression, you would still have a child who would be, it's not necessarily, you would either withdraw care in a child which family won't, then you would probably go for decompression. That's the only way forward. And is it possible to do a diffusion of a spinal cord, which can help? Like if there is no restriction, it's more inflammatory, that it might get better over a few months? Nihaal, is that something one can do? You know, of this area, which is compressed, if one can do a diffusion, if diffusion is not restricted, that means this lesion could get better over time with some atrophy, mild atrophy.
I would say it's not progressing, that's it. Getting better or not, that would be difficult. But if there's no restricted diffusion, yeah.
Yeah, that can be like reassuring that this could be getting better, right? Is that right?
Yeah.
And would you, did you, Lokesh, give steroids as well here? Or I don't know what how do you manage?
No, we didn't give steroids here. There was infection, obviously. There was already this one pneumococcus growing by the time this surgery was done. So that's why we didn't give, we didn't give steroids.
Like, did you think of it? Was there a dilemma? Because,
no, because we did, once we got to know the evening 7 o'clock, we had the MRI, and the surgery was done by 12 o'clock in the night. So it was the compression, mechanical compression part was removed. So we didn't actually give steroids, and we didn't think of it. Yeah. Thank you.
Okay, right. Thank you. I think that should be our last case. Let me check.
Okay, thank you, Nihaal. Thank you.
Yeah, all right. Thank you. We'll see you again on